Well, the trial was a trial in patients with early HD. This was a long trial, 78 weeks, and it included patients on all concomitant meds. Patients had some entry criteria that were fairly standard, and they were classified by a total functional capacity greater than 7, which indicated early HD. So this was stage, in Huntington disease terms, stage 1 and stage 2. These were patients we also pre-specified because there already was some knowledge that certain neuroleptics and chorea drugs could undermine the results and impair the results. So we then looked, and the endpoint was the total functional capacity, and also the most important secondary endpoint was the cUHDRS. That measures 4 components that contribute to progression in HD. These include total functional capacity, that is 5 domains, measures finance, ability to what you're doing, activities, daily living, who cares for you, employment, cognition measured by Stroop, word, and SDMT, and motor function measured by TMS. In the whole population, the results did not reach significance for a primary endpoint, but we pre-specified looking at patients off ADMs, these are antidopaminergic meds, because we knew these may have impact on our drug. Our drug is a CYP2D6 inhibitor, and these various drugs are metabolized by CYP2D6. So in the presence of our drug, you would expect to see higher levels with the appropriate side effects of sedation, somnolence, difficulty in concentration, and these patients are even told not to drive. And these are the functional endpoints that we're measuring in this trial. When we looked at this particular group, we saw significant benefits. We saw benefits on total functional capacity all the way out to 78 weeks. We also saw, surprisingly, improvement from baseline. Huntington disease is a progressive disease, and the disease goes like this for every endpoint. It's ultimately progressive for everything. Here we saw improvements from baseline up to 52 weeks, and then for every measure thereafter, consistently, the results were better than placebo. We also measured Q-motor, which is a measure of fine motor coordination, and this showed significance all the way out to 78 weeks and never went below baseline. Also, Stroop word measurement also showed improvement from baseline, significant up to 52 weeks, and then again never went below baseline. So these patients' quality of life was preserved. So all in all, for the first time in this disease, there's never been a drug that showed slowing of progression or improvement from baseline in function in any subset of patients. So we were pleased to see that we saw positive effects in patients off antidopaminergic meds. These are neuroleptics taken often for behavior, and chorea meds taken for managing chorea. So we also saw preservation of quality of life. We then also went back to 4 prior studies that had also done this but never looked at without ADM. We did an independent integrated efficacy analysis, which I'll be presenting today to the AAN. And this showed, again, significant benefits now in TFC, because the power, with greater power, with greater numbers. Also in cUHDRS progression, particularly in Stroop and in Q-motor, all of which then replicated and provided consistency with the prior study. In Huntington disease, where we've had discussions with the European regulators that have given us support to submit a marketing authorization for approval in Europe, which will have to go through the whole process, and we will be submitting that sometime in the next few months, going for marketing authorization. Another important point for this drug, complete safety, so no serious adverse events with 15 1,500 patient years. So this is a drug that risk-benefit is in favor of benefit, and we hope to convince the regulators to approve this, which would be approved in Europe in 2025. We are still having discussions with the FDA, the US regulators, and we're waiting their response and working with the FDA to define the path forward for Pridopidine in the USA.